So yes, we are live on the YouTube. Shortly, I'll introduce you. Okay, we start the meeting. Good morning, all. Welcome back to Saturday Club morning meeting. And today we have a very interesting subject titled as deep brain stimulation in neurological disorders. I don't know how many of us actually know this terminology about the deep brain stimulation. So for that, we have Dr. Surit Bhaumik with us. He's a consultant neurologist in Vadodara. He has done his MD Medicine, DM Neurology, SC, FRCP, UK, Human Disorders Fellowship in Toronto in the year 2019-20. His affiliations are Movement Disorder Clinic at WINS, that is Vadodara Institute of Neurological Sciences. He's also affiliated with SSG Hospital and Baroda Medical College. He has 18 relevant publications in peer-reviewed journals, and he has, to his credit, many awards. And his main interest in neurology are neurogenetics, deep brain stimulation, and botulinum toxin therapy. So with this brief introduction, I request Dr. Surit to start his talk. Surit, you have about 45 minutes to talk, and then we'll have about 10 minutes of discussion. So over to you.
All right. Thank you, sir, for the kind introduction. So today I'll be speaking on deep brain stimulation in neurological disorders. It's a very advanced surgical technique, and it's really a boon for patients with certain disabling neurological disorders. So what is deep brain stimulation? Basically, in this technique, thin electrodes, like electrodes which have less than 1.5 millimeter diameter, are implanted within certain deep areas of the brain. And these electrodes are connected to a pacemaker with the wires. And these electrodes generate electrical impulses that affect certain cells and chemicals within the brain, within the vicinity of the electrodes. So basically, deep brain stimulation is helpful in improving quality of life in selected patients with advanced Parkinson's disease, disabling dystonia, and disabling tremor. And it is also being used for certain other neurological disorders like epilepsy, tics and Tourette syndrome, and in some certain psychiatric disorders like obsessive compulsive disorder. So the main indication for this advanced technology is Parkinson's disease. So I'm going to talk a bit about this condition in next few slides. So it's a degenerative disorder of the brain. Predominantly, there is degeneration of the neurons which release the chemical known as dopamine inside the brain. Now, dopamine is very essential for our normal body movements. Those who are deficient in dopamine have certain signs and symptoms. These are collectively known as Parkinsonism. So the cardinal 6 signs of Parkinson's disease are bradykinesia, which means slowness of movements; tremor, which is predominantly present in the resting state; rigidity, it means stiffness of muscles; freezing of gait means the patient gets stuck whenever he attempts to walk; loss of postural reflexes means he has difficulty in keeping his balance while getting up from chair or while walking; and his posture is abnormal, like he assumes a flex posture if the disease is progressing. So this is a video of a very early Parkinson's disease. If you are able to see the video, the left-sided movements are slower compared to the right side.
Okay, very good. Big taps like this, big and wide, big and wide. Keep it going.
So patients need not have all the cardiac signs of Parkinson's disease. Like many of these patients are missed in the clinics.
All the way around, all the way around.
In the beginning, they may just have tremor,
Okay, and then try the left hand for me.
or they may have slowness on one side of the body.
Fast, as fast as I can go.
Yeah, as fast as you can go, keeping it
So
nice
you can
and
see the
slow.
right-sided movements are so fast, but left-sided movements are slow.
Can you make a fist?
So if the disease is allowed to progress, the patient looks like this. The face appears masked, like there's less facial expression. The patient has tremor. Patient has slowness, and this is freezing of gait. Means the patient has difficulty in walking because his legs get stuck. This can happen while starting. This can happen while turning. He's trying to turn, but he's not able to turn.
Can you make a fist? Open, close.
Sorry. So when the disease progresses, patients develop two types of complications. One is wearing off, means patients are taking medications, and they are getting benefit out of the medication, but as soon as the benefit wears off, there is re-emergence of all these motor symptoms of Parkinson's disease. So if you can see this patient who was on treatment for Parkinson's disease, but when she stopped the medications for Parkinson's disease, she's so slow. Her face looks expressionless, the movements are slow. And she has difficulty in getting up from the sofa. And she has slowness while walking. So when she is given medication
बड़ा
for
बड़ा कीजिए
Parkinson's
और
disease,
जितना फास्ट हो सके उतना फास्ट कीजिए
her movements improve.
उतना फास्ट लेफ्ट साइड का जितना फास्ट हो सके उतना फास्ट
Movements improve.
कोशिश
She is able to get up.
वेरी गुड अभी उठने की कोशिश कीजिए वेरी
She is able to walk.
ठीक है वापस जाइए
But it appears that she has some involuntary movements of her body, like she's dancing a bit while walking, while performing actions. This is known as dyskinesia. Dyskinesia means involuntary movements. Sometimes they are subtle and patients are not aware of such movements. Sometimes they can be very violent, just bothering the patient. So as the disease progresses, patients develop bothersome motor complications, means they do not have consistent response to medications throughout the day. If you can see, this is the level of the medication that is fluctuating over time throughout the day. As the disease progresses, the fluctuation is more. So when the medication level goes down, the patients have off period, means they are slow, they are stiff, they have tremor. And when the medication is at peak, they may have involuntary body movement, that is known as dyskinesia. So it becomes very challenging for a patient because they don't have consistent effect of the medication every time. They have to take the medication multiple times in a day, maybe every 1 or 2 hours. And not all time they will have good benefit out of the medication. Sometimes they will be off even after taking medication, and sometimes the dose will be, sometimes the level will be so high that they have bothersome involuntary movements. And it becomes challenging for us to treat them with just oral medications. So what are the treatment options that we have for patients for Parkinson's disease? Yes, we have some oral medications. Most of them are available in India, some are not available in India. But even after adjustment of these medications, sometimes it's very difficult to control the symptoms because the patient may spend hours and hours of the waking time in the off period when they are slow, they are stiff, they're not able to get up, they're not able to perform any movement, they're not able to carry out their daily activities. There are some parenteral formulations. Some of them are not available in India, while others are there, but they are very costly. Like, for example, an infusion known as subcutaneous apomorphine infusion, which will result in continuous delivery of apomorphine into the blood system, and it maintains the level so that there are no motor fluctuations, but it's very costly, like about 40 to 60,000 rupees per month. Then we have some surgical options. I'm going to talk about the deep brain stimulation, which is the most effective surgical procedure known to date, and it's the safest surgical procedure for patients of Parkinson's disease, and it's shown to have long-term benefits in these patients. So what are the indications for this type of surgery? Like, if a patient of Parkinson's disease has motor complications, which is refractory to optimum medical management, whatever you do with the drugs, they have these complications. They have off period, means they are slow, stiff, about 20% of the day. And if they have dyskinesia despite optimum medications, like they do not have off period, but they have bothersome dyskinesia, and we are not able to increase the drug levels. And these complications must be disabling to the patient enough to justify the surgical risk. Or if they have too much of tremor, and that tremor is disabling enough to justify surgical risk. So what are the necessary requirements for these patients? That they should have good response to medication, but they do not have consistent response to medications throughout the day. And they should have acceptable cognition. That means they should not be demented. They should have stable psychiatric features. They should not have any suicidal ideation. Certain requirements are desirable, but like they should not have too much of comorbid conditions. They should have some caregiver support. There should be at least some disease duration of 5 years, and age less than 70 years is desirable. But patients who are like between 70 to 80 years of age can also undergo this surgery if they're very disabled from the disease. So how is this surgery done? It requires a multidisciplinary team and movement disorder specialist, like neurologist who is trained in treating these disorders, is the central person leading this team. And basically he guides what procedure needs to be done and what programming needs to be done. You need a neurosurgeon who is trained in such procedures. You need the backup of psychiatrist, neuropsychologist, a physiotherapist, and some trained supporting staff. So whenever such patients come to me, I have to make them undergo following tests. I have to see whether they still respond to medications or not. Now, the major determinant whether the patient will benefit from this surgical procedure is the response to medication. So you know that in Parkinson's disease, we give levodopa. Levodopa is the main drug which gets converted into dopamine inside the brain. And if they have at least like 33% improvement in their motor symptoms by giving levodopa, it means that they are a good candidate for surgery. When they are not responsive to this medication, means that they could be having some atypical Parkinsonian syndrome. There are some disorders which mimic Parkinson's disease, but they are worse than Parkinson's disease. In those diseases, the balance is lost early, the speech is lost early, and they are more disabled than patients of Parkinson's disease, where this surgery is not indicated. In these disorders, surgery is not indicated. So this is the major determinant. And then I make them undergo cognitive evaluation. I have to check their memory. They should have a stable neuropsychology evaluation, and the MRI of the brain should show that the brain is healthy enough so that the surgery can be done. Of course, I discuss whether they have proper caregiver support or not. I discussed the realistic expectations that surgery doesn't cure the disease, but it improves the quality of life. If you are just on medications, the quality of life is this. If you are undergoing surgery, then the quality of life can be much better. And of course, I discussed the risk, surgical risk, and the side effects of this stimulation. So what do we do in this surgery? We select the targets. So for patients of Parkinson's disease, there are three. for Parkinson's disease, there are 3 possible targets. One is subthalamic nucleus. Satish sir, am I audible to you?
Yes, yes.
Okay, I'll go on. So the main target is subthalamic nucleus. It's for patients who have a lot of off symptoms, means they have the benefits of the medications wear off quickly and they spend too much time being slow, stiff. The patients who have violent dyskinesias, in those patients, globus pallidus internus can be a preferable target. And rarely Wim nucleus of thalamus is selected for those patients who have high amplitude tremor, and this tremor if they are perceiving as bothersome. So how does DBS work? Nobody exactly knows, but I just mentioned briefly that these electrodes generate electrical impulses around them, and they affect the nearby neurons and release of chemicals. And I'll just briefly mention what we do in this DBS procedure. So the patient, 1 day prior to surgery, undergoes MRI of the brain with contrast. And then on the day of surgery in the morning, a frame is placed. This is a stereotactic frame that is placed around the head of the patient. And with this frame, the patient undergoes CT scan. Once we have the CT scan as well as the previous MRI, we fuse them in a planning station to get a 3D map of the brain. In this planning station, we plan the trajectory that we should take while placing the electrodes at the desired target. By doing a proper MRI of the brain and CT scan with contrast, we are able to visualize all the vessels in the brain, and while doing planning, we check that we are not hitting any vessels. So this surgical procedure is very, very safe, and it has 1% chance of intracranial hemorrhage, which is usually not very severe. So after this planning, we take the patient in the operation theater, and this surgery is mostly done when the patient is when patient is conscious, means the patient doesn't undergo general anesthesia in the beginning. Under local anesthesia, some holes are placed in the skull and the electrodes are placed with stereotactic guidance. So while inserting the electrodes, we are able to hear some sounds that are generated by the neurons in the brain. This is known as microelectrode recording. And through these sounds, we are able to identify where the electrodes are exactly. And the rationale of keeping the patient conscious is that we'll be able to see the effect of stimulation. Once the electrodes are at the desired location, we stimulate to see if the patient has any side effect or not, and if the patient is benefiting. So, for example, the patient was very slow because patient had to be kept off medication for the surgery. And then when we stimulate, she's able to do finger movements like this. So by this, we are able to assess that the electrodes are in the proper positions. Once we are certain that the electrodes are in the proper position, then the patient undergoes the next step under general anesthesia, means battery or internal pulse generator is placed underneath the skin of the chest, and this is connected to the electrodes via some wires. After the surgery is finished, nothing is visible from outside, everything is inside the body. Okay. And then after the surgery is done, we call the patient back after interval of maybe 2-3 weeks. In some centers, they are called back after an interval of 4 to 6 weeks, and then we do programming. So this is a tablet. This is a Samsung tablet of Medtronic, which can be connected to the pacemaker via Bluetooth, and we can do the programming there. So how do we do the programming? So once we are placing the electrodes, now the electrodes has several contacts which can be stimulated. So we have to select the best contact by stimulating and seeing the effects on the patient, whether the patient has any benefit or whether the patient has any side effect. And then we select the optimum contact on both sides. And this contact can be stimulated in multiple ways. Like there can be monopolar stimulation, there can be bipolar. I mean, two contacts are selected, one is positive, one is negative, and multiple level contacts can be selected. And some leads are there where you can produce directional electrical impulses. So we have a lot of parameters through which we can guide the electrical impulses around the electrodes. There are also other variables, like for example, we can play with the amplitude, we can play with the pulse width, and we can play with the frequency of the pulses that are delivered to the electrodes. And by changing these variables, there are numerous programs can be created in the pacemaker to stimulate the nearby neurons. And each parameter has some benefit or side effect that we have to adjust based on the patient profile. So when the patient comes initially, and the patient is off DBS, means patient just had surgery, but the pacemaker is not turned on. We check the baseline motor symptoms, and especially when they're off medications, then the electrode position is checked. Electrodes are labeled, resistance, or this impedance means resistance are documented, and then we start programming. Okay, as I mentioned, we have to select the contact. That's the best contact. It means we have to see the benefit and we have to see the side effects. So if you can see, there are 4 contacts here, 0, 1, 2, 3, and one contact has the maximum therapeutic window. Means at lower amplitude, she has benefit, and we keep on increasing the amplitude. After a certain threshold, she will develop side effects. So this is the highest therapeutic window, and then that means that we will be selecting contact 1 as the point of stimulation. So in subsequent programming sessions, we optimize the stimulation parameters so that patients' realistic expectations are accomplished, medication regimen is simplified, and adverse effects are minimized. So I'll just show you a video of this patient. This patient I showed you before. So patient already had a DBS. Patient had a DBS surgery at our center, and she was called 2 weeks later. She is off medications, and the DBS is not turned on yet. You can see that the face is expressionless, the movements are slow. And you see how difficult it is for her to get up.
Okay.
And then she has slowness while walking. So this is her off period, and she used to spend about 7 to 8 hours per day in this off period. And this is the effect after turning on the stimulation. She's still off medication. This is the effect immediately after turning on the DBS. Facial expression has improved a bit. Her movements have improved, and she's satisfied with the degree of her movements.
Okay. जितना फास्ट कर सकते हो उतना फास्ट कीजिए. Okay.
Look how quickly she's able to get.
Oh, great. हाथ नीचे रखो. चल के दिखाइए. और आराम से.
And look how speedily she moves. We had to tell her that please move आराम से. So this stimulation, although it is a revolutionary treatment option for patients with Parkinson's disease, can have some adverse effects, like the speech may get worsened. There may be difficulty in swallowing. If the patient already has a lot of freezing, the freezing may worsen. If the patient already has a lot of balance issues, balance may worsen, and they may have certain non-motor features like memory issues, depression, apathy, and some withdrawal syndrome if the drugs are withdrawn very quickly after the procedure. So it is important to determine if these adverse effects are part of the disease progression, or they are ongoing problems worsened by the DBS, or they are pure adverse effects of the stimulation. And we are able to we will be able to troubleshoot if we are able to determine what is the leading cause of worsening symptoms. So, and so we have, as I mentioned before, we have several program variables, like we can modulate the electrical impulses in various ways, and then we can play with the parameters like amplitude, frequency, and pulse width. And by creating several programs, even if the patient has side effects, in majority of them, we are able to bypass those side effects by just doing some adjustments. That is in the coming year. They don't develop the side effects soon after DBS, but they may develop some side effects due to progression of the disease few years later after the procedure, and then we have to do the troubleshooting. So this is a slide showing long-term outcomes. If you can see the off period here, this is the blue line, which is before DBS. And these green lines are after DBS, like after 5 years and after 8 years after DBS. And you can see the scores, higher the scores means worse the patient. And with DBS, the scores are much less when the disease is followed for about 8 or 10 years. So this is just, I just talked about the DBS, which can be manually adjusted, means we see the patient, we stimulate and see the benefit and side effects, and then we manually adjust the parameters. This is in current use right now, but people are developing technology where the electrodes can sense some signals in the brain, like some local field potentials in the brain, which change based on patient's movements, based on patient's symptoms. And if these electrodes are able to sense those signals, they can automatically generate impulses or in a specific manner to counteract the symptoms. So this is known as closed loop or adaptive deep brain stimulation. And if they are able to develop this technology well, this can also be a boon in patients, because then the side effects will be minimized and the battery use can be prolonged. The goal of DBS is not to cure the Parkinson's disease and not to fully withdraw the oral medications. The goal is to simplify the dosing regimen. The goal is to improve the quality of the life so that the patient doesn't spend too much time in the off period. And the off period is not very disabling. But there are certain challenges that keep bothering as the disease progresses, mainly the axial motor symptoms like balance, freezing, and swallowing, and certain cognitive disorders, cognitive issues like memory issues, and then psychiatric issues like depression and apathy. So this was the main indication for DBS, Parkinson's disease, but then there are certain other important indications for considering deep brain stimulation. Dystonia is another disorder where, because of the disorder of the brain, the body assumes a twisted posture, or body has spasms in several parts of the body. Example, if you see this patient, I'm asking the patient to keep the mouth open, but because of spasms in the jaw, is not able to keep the mouth open. This causes difficulty in eating and swallowing. And he has blepharospasm, means he is not able to keep the eyes eyes open, and this leads to functional blindness. So for this type of focal dystonia, and this is another patient of focal dystonia, and the patient has cervical dystonia, and look how disabling it is to him. So these hand movements are some compensatory movements. He's trying to make himself comfortable. And this is known as sensory trick, which alleviates the dystonia. But really, these symptoms are very disabling to some patients. And often these patients are, because of affordability issues or before they are not offered proper treatment, they remain disabled for several years, a lifetime. Actually, for this kind of focal dystonia, botulinum neurotoxin therapy is the treatment of choice. And patients are often not offered this type of therapy, and they are just maintained on oral medications, which are not at all effective or not very effective. That sometimes dystonia can be generalized, means multiple body parts can be affected, or the trunk can be affected, like this boy. Look how disabling the disease is. His mouth is open. He's not able to place his legs properly because the feet are plantar flexed. And her younger sister is also affected. Like, look how the hand goes whenever she tries to move. Okay, so for these kind of patients, botulinum toxin doesn't help, because you have to inject multiple body parts, and it overshoots the limit of the dose. So for these patients, you have oral medications, but they are not usually very effective. The treatment of choice in this patient is surgical therapy, and the deep brain stimulation is the most most safe, or sorry, most effective or the safest surgery, because it allows programming to be done, as against surgeries like pallidotomy, where you have just created a lesion. So this globus pallidus interna is the target of choice for these patients, and it's really a game changer in these patients, because they make the patient much more comfortable. One more indication is tremor. So some patients have fine tremor, but other patients can have bothersome tremor that affects their routine life. So this patient has action tremor, means whenever he tries to use his hand for actions, he has tremor, which causes difficulty in performing action. So in these patients, what do we have? Like, we have oral medications, and these are like, for a patient who has fine tremor, okay, these medications may work, but for this degree of tremor that in the video I showed, the propranolol, which is the most effective medication, but its efficacy is like 50% at best, and most patients do not tolerate higher dose of this medication. And similarly, other medications are less effective, and they are not tolerated because of higher risk of side effects. So for these patients also, we have surgical therapy, and deep brain stimulation of the thalamic nucleus, WIM nucleus, is a very, very potent technology to reduce the tremor, and the patients have long-term, despite the some emergence of tremor in the later part of life after the surgery, they can also be controlled if you are able to program the stimulation parameters. So with this, I finish my presentation. It was just a brief overview of this advanced technology. So this is a patient that I showed in the beginning, and then after the surgery, and now the patient is able to carry out her daily activities. She has recently joined gym. Her main regret before the surgery was that she was not able to perform well in the gym. She was not able to maintain her lifestyle, and look, she is back to where. Many people consider slowness as part of aging process, and they do not seek treatment. And those who seek treatment, they usually are not keen to undergo advanced procedure, because they have not been counseled that, okay, this can improve the quality to such an extent that you'll be able to carry out all your activities independently. And they are often just treated with oral medications despite all the disabilities. And I think we should create more awareness of this technology, and make the patient's life comfortable.
So thank you, Shorit. That was wonderful presentation on something which most of us actually, at least as a pediatrician, I do not know much about it. So now the session is open for question answers. I believe there will be a lot of questions about the logistics, cost, etc. So yeah, check this way.
Yeah, basic question is, doctor, that if it is a neurodegenerative disorder where chemicals are decreased, how stimulation would improve the availability of the chemicals.
Yeah, so Parkinson's disease is a neurodegenerative disorder in the sense that there is degeneration of the neurons, but basically there is degeneration of the neurons which release a chemical known as dopamine. And knowledge of this fact allowed us to find a treatment which improved the quality of life of most patients. Like the drug levodopa was a game changer when it came into use. So after certain years of using levodopa, people started realizing that, okay, there is a first honeymoon period when they will be responding very well to the medication. Then after like 5 to 10 years, they will have these fluctuations. Means initially there are in neurons sufficient enough to store the dopamine that forms out of levodopa, and this acts as a buffer. So even if the blood levels of levodopa fluctuate, the neurons that are storing dopamine, they're releasing some dopamine inside the brain, and you do not see fluctuations initially. The patient has good benefit of the medication throughout the day. But as these neurons degenerate, now they don't have the buffering capacity. And so the patient will respond depending upon the blood level. So when the oral medications are taken, there are multiple factors that affect its absorption and its availability to the brain. The tablet has to get absorbed, then tablet has to reach the blood, and then tablet has to reach the brain. So some of the times, like 50% of the drug may be absorbing. Some of the
the patient will respond depending upon the blood level.
Sorry, I don't know what happened. So they develop fluctuations. So what does deep brain stimulation do? It provides direct access to the areas which are important in the circuitry of the disease. So it stimulates the nearby areas, and this modulates the circuitry, and you can see the immediate effect. Like the tremor will be gone immediately. Bradykinesia will be gone immediately. There will be improvement in the movements. Rigidity will be gone immediately. And then over the time also there's some modulation which leads to overall improvement in the quality of the life. Maybe they allow release of more chemicals inside the brain, more dopamine inside the brain by stimulation of the nearby neurons. So that also helps. But that is just one hypothesis. Main hypothesis is like stimulation or modulation of the circuit that leads to control of the symptoms. So this is one degenerative condition for which deep brain stimulation works. We don't know the stimulation parameters or the efficacy in other neurodegenerative disorders like dementia. It's being tried, but we don't know the stimulation parameters. We don't know whether it works or not. Somebody asked about the cost. So I'll simply say that 1 lakh per year. So suppose there are different types of batteries or the program, the pacemakers available. So some pacemakers would last for 4 years, and then you have to change the pacemaker. You don't have to undergo the full surgery. You just have to change the pacemaker. This pacemaker in a private practice, like the entire surgery and everything, will cost about 12 lakh rupees in a private setup. In government setup, it may even cost lesser, like 8 lakhs. But they have to travel to some designated centers like AIMS, PGI, or NIMANS. Some batteries are rechargeable batteries, means you have to recharge the battery with a wireless charger once or twice in a week. And those batteries can last for 15. This is preferable for younger patients. Like these batteries can last for 16 years, and there are some companies which have batteries that they claim last for 20-25 years or more. So these are like for one company like Medtronic, if you are choosing a rechargeable battery that lasts for about 15 to 16 years, the cost will be roughly 16 lakh rupees in a private center.
Yeah, Dr. Hemant.
My question is, during the surgery, how does the electrode reach the substantia nigra exactly? I mean, how is the positioning done? And then
Yeah.
second question is that we have used deep brain stimulation for motor this thing, but for sensory and sleep disorders also it has been mentioned.
Yeah, not this exact deep brain stimulation, but there are some other forms of stimulation that has been applied for certain non-motor symptoms like neurogenic bladder or not exactly sleep disturbance, but you can say depression, OCD, and all these things, but it's not yet approved for sleep disturbances. So regarding the first question, how does the electrode reach the target? It's not substantia nigra, it's subthalamic nucleus. That is the main target for patients with Parkinson's disease. So we do the mapping first, mapping of the brain. So we do MRI of the patient with contrast, and this MRI, we have a technology in the MRI which can guide us to the exact location of the subthalamic nucleus. I mean, some of the nuclei appear black because of the iron content in them. The red nucleus, substantia nigra, these appear black, and we have some scales to know the exact position of the subthalamic nucleus based on the nuclei that we are seeing in the MRI. And then again, this MRI is fused with a CT scan, and there are planning stations which are able to generate a 3D map of the brain. And we have like a lot of data from, especially from the Western world, and they have an atlas. And by looking at the scales given in the atlas, we are able to map the location of the subthalamic nucleus. We are able to visualize the subthalamic nucleus, and then we are able to plan a trajectory from top to the subthalamic nucleus by avoiding all the vessels and by avoiding certain areas of the brain which would cause side effect.
It is done in an MRI suite or an operation theater?
Sorry?
Is the procedure done in an MRI center or operation theater?
Operation theater. MRI is done 1 day prior to the operation for mapping.
Thank
So
you.
how many centers do this procedure? Like in India, in Gujarat, do we have any center?
Yeah, our institution has started doing.
SSG has also started doing it.
Not SSGH. We don't have that much developed neuro lab or navigation center in the SSGH. We have this center in the WINS. We did one surgery in November, and the patient I showed you in the presentation. And we have done one more procedure where we just replace the battery. So we are starting this procedure here, and there are centers in Ahmedabad which also do this procedure, and multiple centers across India do, mainly where movement disorder experts are available. So in Mumbai, Jaslo, Global, the Kokila, they are all
corporate hospitals have that.
Yeah.
You mentioned about AIM, that's why I was wondering whether
so tertiary care centers like AIMS is doing. PGI has not started yet. AIMS is doing, and then we have Nimhans doing. We have Sri Chitra Institute in the Kerala that is doing.
So some of the centers where the cost could be less, like government centers.
Yeah, because their admission and the bed charges, all these things will be not there. So the cost will.
Is there any age limit to this?
Yeah, ideally is like if the patient is less than 70 years, means patients who expect to live more than 10 years to 15 years, in those we offer surgery quickly. But the patients who are disabled between 70 to 80 years of age, if they want, they can also undergo surgery. If the brain is relatively healthy and they don't have much comorbid conditions, they can also undergo surgery. In India, like a lady at 83 years, like this is the oldest person I know has undergone surgery.
Right. Any other questions or comments?
Any other complications over it, like breaking off of the electrodes?
Yeah,
Incident?
these complications. So we have to take care of the patient and select the patients properly. We don't we cannot select patients who are not cognitively well. In some of the patients who are demented and they don't take care of their body, they can keep on scratching the wires, the place where the wire goes, and this can lead to some wire-based complications. And yes, sometimes electrodes also get damaged. Electrodes are very fine and they also contain several wires. Sometimes they can get damaged, but because it is like, even if one of the contacts gets bad, we can like select the other contact, avoid stimulation of the specific contact, and we can bypass some of the complications. A major worry of this surgery is intracranial hemorrhage during the surgical procedure, which I told you that the chance is very less with the current neuroimaging techniques. And if it still occurs, it's very less and it's usually not symptomatic. And the second fearful complication is infection. If the patient develops infection, then the total surgery is a waste. Like, we have to remove the implant, and because we cannot afford any infection going into the brain, and for a very long time we won't be able to do the procedure again. So chances of infection are like 3 to 4%, and we have to take good care of the patient.
Yeah, I have one question. As we have radio frequency ablation from outside, is there any technology which can stimulate from outside?
No, unfortunately, no. We don't have a technology which can stimulate. Like, if you are talking about transcranial magnetic stimulation,
Yes.
this is one modality that is being used for diseases like Parkinson's disease, dystonia, tremor, but the effects are very short term, and patients usually do not get any meaningful benefit, so that they can carry out their daily activities at home. It is good for those patients who have like focal dystonia, like writer's cramp, and just for this difficulty in writing, they may not choose to undergo this expensive surgery, and they may not take the surgical risk. So for those patients, transcranial magnetic stimulation can help, but it has to be given persistently, because after few weeks or months, the effect goes away. Unlike deep brain stimulation, which the effect persists because of the continuity of the stimulation.
So carrying it further, Dr. Subrit, is there any future of DBS in terms of use of artificial intelligence?
Oh, it's already started. So it's already started. So, I mean, we actually don't know. I just mentioned the one closed loop technique where the electrodes sense the signals from the brain, and the system is taught how to handle those signals. If they get one type of signal which correlates with tremor, and the patient has a bothersome tremor, then the system will sense that signal and automatically deliver a stimulation parameter that will control the tremor. When the patient tries to move and the patient has slowness, and it generates a different biomarker, a different signal in the brain, if the system can sense the signal and the system is taught to respond in a specific manner, then again a specific stimulation parameter can be delivered which improves the movement of the patient. If the patient has some side effect, again the brain they can sense and adjust the simulation parameter. So this is already ongoing, and we have reached a certain stage where these are being proved effective in certain trials, but we have to see in the real world how effective it is.
can this go haywire and cause a lot of undesirable movements, etc.? Like,
yes. So undesirable movements can be there without deep brain stimulation. Like it can be a side effect of, like dyskinesia can be a side effect of medications, and these side effects don't allow us to increase the dose of medications or add more medications. So DBS can also cause dyskinesia, but it has been seen that patients who are just on medications plus patients who are on medications plus DBS, they have better control of these involuntary movements than patients who are having DBS. Even if they have such side effects, we can play with the parameters. We can change the stimulation to lessen the side effects, lessen those involuntary movements. So by adjusting both medications as stimulation, we can stabilize the patient. So important thing is that patient will not improve magically after the surgery. We have to turn the stimulation on, and we have to give at least 6 months time so that the modulation effect takes place and the patient is stabilized.
I think there are not many questions now. So thank you, Surit, for very wonderful, elaborately talk on this new technology for us. Thank you so much. We look forward to some more talks in future.
Sure,
so
sir.
Thank you all. And next Saturday, we have Dr. Ravi Shah from USA. He's a cardiologist and electrophysiologist. We'll be talking more about historical perspectives and review of current practice in cardiac defibrillation. So an interesting topic coming up. So see you all next Saturday again. Thank you. We end the session here. Thank you all. Thank you.
Thanks, sir.